All right, I think we can go ahead and get started. We're a couple minutes after 7. First off, thank you all so much for being here. We're so excited to have such a great turnout, especially for an event that absolutely deserves as much attention as possible. But before we get to our fabulous event tonight on defending Medicaid from historic cuts with Mr. Leonardo Cuello, who has very graciously offered his time to be with us here today, just want to start with a little intro about Doctors for America, which is the organization hosting this event. Just for starters, my name is Raj Reddy. I'm a medical student over at Baylor College of Medicine at Houston, Texas. I'm also the chair of the Access to Affordable Care Committee for Doctors for America. Um, so I actually want to take a quick minute to invite you all to officially join Doctors for America. Being a DFA member today means taking the important and simple step of selecting a membership level and paying your annual membership dues to support DFA's organizational sustainability and incredible programs like this Advocacy Round series. There are 4 different levels to choose from, and a DFA team member will be putting a link to join in the chat. Also, just to highlight some of Doctors for America's other really important work, DFA, represented by Public Citizen Litigation Group, actually just filed a lawsuit on February 4th, 2025, against the Office of Personnel Management, OPM, the Centers for Disease Control and Prevention, or the CDC, the Food and Drug Administration, or FDA, and the Department of Health and Human Services, or HHS, for the removal of a broad range of health-related data and other information used by health professionals and researchers from publicly accessible government websites. If you're interested in finding ways to get involved, help is absolutely needed to identify web pages and data sets that CDC and FDA removed from their websites. A link will be provided by a team member in the chat where you can describe the pages that you were using and share your stories about how the loss of access to this public government data has affected you. Providing this information allows public citizen to make sure that the agencies restore them as ordered by a federal judge. This session will be recorded and all session materials will be available afterwards. A few quick ground rules for this educational session. There's absolutely no such thing as a dumb question. And speaking of questions, please remember to use the Q&A feature for those versus the chat. We'll address your questions during the second half of our session, but again, use that Q&A function so we can make sure that they go through the proper channel for our panelists to be able to view them properly. And also look out for any comments in the chat from DFA staff because they'll be sharing helpful links during the session as well. So now I'll move on to introducing our wonderful speaker, Mr. Leonardo Cuello. Leo Cuello is a research professor at the Center for Children and Families in the McCourt School of Public Policy at Georgetown University. His areas of focus include Medicaid litigation, demonstrations and waivers, managed care and delivery system reform, and immigrant health. Before joining CCF, Mr. Cuello was a health policy director for the National Health Law Program, where he worked on a wide range of Medicaid issues, including litigation around work requirements, which we'll hear a lot more about tonight. Prior to that, Mr. Cuello worked for the Pennsylvania Health Law Project, focusing on a wide range of healthcare issues dealing with eligibility and access to services in Medicaid and Medicare, and direct representation of Medicaid enrollees. Mr. Cuello graduated the BA from Swarthmore College and received his JD from the University of Pennsylvania Law School. So without further ado, I'll turn it over to Mr. Cuello to provide us a look at the evolving Medicaid landscape under the new administration.
Thanks so much, Raj. Good evening, everyone. I want to thank Doctors for America, the team, Sophia and others for having me here tonight, and all of you for joining us after I'm sure what was already a long day for many of you. I'm so happy to be here, and I want you to know that many of us in the policy world are really noticing the way that Doctors for America is engaging right now and stepping up, and we really appreciate you. So just want to put that out there. That was a great intro, so I won't say anything more about myself except one fun fact, which will tell you another reason why I'm happy to talk to a group of physicians, which is that I am the child of not one, but 2 pathologists, both my mom and dad. So, it was an adjustment for me when I found out that cadavers are apparently not a normal dinner time conversation topic. So I'm very comfortable with physicians. So anyway, in a well-functioning world, I would be here today to talk to you about the ways Medicaid can help you better care for your patients and learn from you about how Medicaid could work better for doctors and patients. But unfortunately, I'm here in a desperate hour to share a red alert about historic cuts to Medicaid that are being considered right now. So this is not a drill. I am really not here to waste your time or teach you something theoretical. This is real and happening right now. So what I'm going to do is I'm going to give you some Medicaid context, and then we're going to get into the huge cuts that are on the table. So first, we'll cover the Medicaid background. So I want to start by just reminding us how many lives Medicaid covers. This slide actually understates it. It's 72 million in Medicaid and another 9 million in CHIP in the 2024 October enrollment data. So, that's a lot of people. It's more than Medicare, which I think surprises many people. I also want to say that in addition to the sheer number of people, there are all of these roles that Medicaid plays for our society, from long-term care to substance abuse disorder treatment to mental health services, covering nearly half of all births, nearly half of all children, and playing a key role in pandemics and the pillar that keeps rural health care open and functioning. So first and foremost, we care about people and all of their needs. But it turns out that Medicaid is also critical for states and all of our other goals. And I'm going to show you two pie charts now that we will just look at in combination. Here's the first one showing you the federal dollars flowing into states. And you can see that 56% of the federal funding states get is for Medicaid. And note that K through 12 education and higher ed combined account for 13% of the federal funding coming in. So we have 4 times more money, federal money, coming into states for Medicaid than we do for education. And now we look at our second pie chart. This one shows what states spend their own state dollars on. And you can see now Medicaid is less than 20%. And you have states putting 43% of their money into education. So states are spending over twice as much of their own money on education. And so these slides are telling you a story. States are getting generous federal funding for Medicaid, and that is enabling them to pile tons of their own state dollars into education, into other priorities. So yes, Medicaid is about human lives and healthcare, and we care about that. But Medicaid financing is the backbone of state budgets. And I'm sure you all want your patients to both get their inhalers and, learn how to read, right? So if you defund this Medicaid system, how do states continue to pile all that money into education, right? This is a disaster for states if you mess with this Medicaid funding system. So we're going to talk about cuts, and to understand those cuts, we're going to need to understand some basics about Medicaid financing. And there are 2 basic points here. First, Medicaid financing for states is open-ended. When a state spends a state dollar on healthcare, they get a federal matching dollar. And those federal matching dollars rise to meet whatever level of need the state has. So as the state spends a dollar, it gets a dollar. And it's open-ended to meet that need wherever that need is. And that's critical for states to keep up with healthcare inflation, right? Expensive new drugs and treatments, but also when there's a recession, when there's a natural disaster, when there's a pandemic, and we have a sudden surge in state need, federal funding is always going to be there to meet the need. Our second point is understanding how the dollar for dollar match happens. Turns out the deal is actually better than a dollar for a dollar. Every state has what we call a federal medical assistance percentage, called an FMAP. It's just the percentage of costs that the federal government ultimately pays. And states range from 50% to 77%. That percentage each state gets is set by a wonky formula based on how much per capita income the state has. And basically what it does is a more wealthy state, like a New York or a California, the feds will pay 50% of the cost. So that is actually a 1-to-1 match. But in the poorest state, which is currently Mississippi, the state pays 23%, the feds pay 77%. So for every dollar that Mississippi puts in, the federal government is actually putting in over $3 in federal match. The median state spends about $1 to get $2 of federal match. So that's how the standard matching rate works for Medicaid funding. There are also some special matching rates. And for our purposes, the big one to know about is that for Medicaid expansion, there is a flat 90% rate for all states. So all states in the Medicaid expansion context spend $1 and they get $9 in federal matching funds for Medicaid expansion. So our two basic points are the matching is open-ended and it's based on a formula that tells us what percentage of the bills the feds pay. In case you're curious, there's a link here to a chart from KFF, which will tell you what the matching rate is in your state. So that's sort of our whirlwind on background. And so now we can start getting into these actual cuts that are coming. So what's going on right now? And I mean right now, literally right now, Republican federal legislators are considering massive, historic cuts to federal Medicaid funding. They're considering various legislative priorities, border and immigrants, defense, energy, tax cuts, and proposing to cut Medicaid to help pay for all of those other priorities. To do this as a matter of process, they're going to need to use a legislative process known as budget reconciliation in order to avoid filibuster by the Democrats in the Senate. Budget reconciliation is this fast track process for fiscal legislation. So it's only for legislation that has a budgetary impact. And if you go through this budget reconciliation process, you only need a majority in the Senate. You don't need to get past the filibuster. And budget reconciliation is basically a two-step process. First, savings targets are developed for the legislative committees in each chamber. So just a number, like what's your target number? And then second, committees then write legislation, policies, to hit the target they've been assigned for their particular committee area. And so right now in the big picture, we are in step one of this process. Committees, each chamber figure out what its targets are going to be. Importantly, both the House and the Senate must ultimately come to agreement on the final package by the end of the day. So how big might these cuts be? Well, no one knows where this carousel is going to end up. Here are the data points we have right now. By the start of the process, House leadership had already committed to cutting $2.5 trillion over 10 years. All these numbers I'm going to give you today are kind of over 10-year numbers. And they were going to cut $2.5 trillion in existing spending in order to get past the debt ceiling issues and resolve the House speakership, right? So those are kind of commitments leadership made, not just in Medicaid, but all across everything, 2.5 trillion, an unfathomably large number. The current target being considered in proposed legislation in the House is between 1.5 and 2 trillion cut to existing spending. To be clear, the overall impact of this is still to raise the deficit because they are cutting 2 trillion over here in spending, largely targeting Medicaid, but they would be adding 4.5 trillion in tax cuts, right? So this is actually a huge net cost. Several weeks ago, the House Budget Chair circulated what we all refer to as the menu, the possible cuts to spending, including Medicaid spending. And so it sort of lays out many different ideas to cut Medicaid. So I'll call that the menu. And that listed $2.3 trillion in options for cutting Medicaid. The proposed target in the House right now would specifically target $880 billion of cuts for the committee, Energy and Commerce, that handles Medicaid. Again, that's $880 billion over 10 years. There really isn't a lot of other policy for that committee to target. So this is effectively all or almost all $880 billion that would be hitting Medicaid. Importantly, that target that's adopted would be a minimum. So they could go higher and there'll be a vote. They're saying they'll have a vote on the target next week on the House floor. So to give you a sense of scale, total federal Medicaid spending in 2024, the whole enchilada was $584 billion, right? So $888 billion it's just a huge number. But of course, that's the current snapshot. No one can say where this will end up at the end of the House process, much less once that process is finished and then they have to come into agreement with the Senate. So what's on the menu of Medicaid cuts? The short answer is a lot. Here's a list of the top 5 things to know about that we're going to talk about because they are by far the most damaging potential cuts, and all of these are in play right now. So number 1 on our list is per capita caps, and there's a variant of the same idea known as block grants. But per capita caps and block grants ends that open-ended matching structure that we talked about, replacing it with a low-ball capped grant. So the state starts getting matching payments until the feds hit their cap. And then after that, there's no more federal funding. The state is unprotected against rising healthcare costs, pandemics, natural disaster, recession, etc. In 2017, the Congressional Budget Office, CBO, evaluated a per capita cap type proposal at the time and found it would cut Medicaid by 26% over the decade, 35% by the end of the following decade. This is probably the single worst thing that could happen to the Medicaid program. This cap could be put on the whole program, or they could target it towards particularly Medicaid expansion, which is one of the things the Republicans like the least. In a moment, I'm going to get into the mechanics a little, but I don't want you to get lost in the mechanics. This is a cut. It results in a gigantic funding cut for states, a cut so big it's impossible for the state to make up for it. The GOP menu lists this as saving $900 billion, which is similar to what CBO estimated in 2022. But I want to be clear, there's no money being saved here. The number of births is not decreasing. The cost of those births is not decreasing. The federal government is just reducing what it's paying for those births, what it's contributing. The state is forced to make up for that cost, right? But no money is being saved here. So why do these caps produce such cuts? Well, the mechanism is devious and effective. It kind of has 2 parts. There's this year 1 funding level. The design typically lowballs the state in that initial allotment. But let's just say that it might be survivable. The bigger problem is in the second part of the mechanism. The people who design these things to cut Medicaid, they say, don't worry, we'll adjust this grant upward for inflation. But they adjust it based on something that goes up half as fast as actual healthcare spending. So every year that capped grant falls behind actual costs, falls behind reality. And over time, the program gets crushed. And the other really bad thing about this is now you have effectively created a dial for the enemies of Medicaid, because anytime they want to squeeze more money out of the program, they just mess with this cap and adjust it downwards a little. So our second big threat, one way to slash state funding is to put in this cap. The other way to achieve a similar result is to lower the matching rate, right? So for each state dollar the state spends, it just gets less federal matching dollars. So they have a lot of bad ideas about how to mess with this matching rate. So one very bad idea is to lower the Medicaid expansion match from 90% to the standard match rate, which recall is 50 to 77%, depending on the state. Viewed from the state perspective, that means the state's cost for doing its Medicaid expansion goes from 10% to somewhere between 23 to 50%. So best case scenario, your West Virginia, whose standard match is 74%, right? Meaning the state's paying 26% normally. And their match goes from 10% to 26, more than doubling the cost, right? Worst case, you're in a 50% match state, and their cost goes from 10 to 50%, right? It literally quintuples the cost. So all states would struggle to fund that kind of a sudden cost increase. And in many states, maybe most states, they would do the math and drop the expansion. It's hard to say how close we might get to all states dropping the expansion, either quickly or over time. There are 9 states where they don't even need to do the math. These 9 states have a trigger in their state law that says if the 90% match gets lowered, they automatically drop the expansion. There are 3 more states that have what I'll call a soft trigger. The 90% dropping triggers some kind of required response from the state's Medicaid agency that could lead to some kind of regression on Medicaid expansion. Just to give an example, North Carolina in the past year has insured 600,000 people through their new Medicaid expansion. They have a trigger. So if Congress drops the match from 90%, boom, over 600,000 people lose coverage unless the state goes back in and repeals the trigger law and at the same time almost triples state funding for expansion, right? Really challenging. Okay. They have another idea to mess with the matching rate, and that's our third big topic, which is to lower what is the minimum match. As we said, the match gets set by a formula, and all states get 50 to 7% match through that formula. But actually, if you only use the formula, some states get less than 50%. So there's a second provision that says all states get at least 50%. So a state that gets less than that, let's say only 45%, they get topped up to 50%. So they have a proposal to eliminate that minimum 50% provision. No top-ups. Effectively dropping the matching rate below 50% in about a dozen states, mostly blue states, that come out under 50% under the formula. Now, all the losses for this policy, right, are only concentrated in these particular states. And since they tend to be blue states, there is some political risk that a reddish legislature might feel more free to make cuts that are only hurting the bluish states. But at the same time, remember that these bluish states do have Republican members of Congress who may not like the idea of their state being targeted. So in case you're curious, our team ran the numbers and found 11 states impacted when we ran the numbers. CBO ran the numbers in 2022. They thought it would impact 13 states. They didn't say exactly which ones, but these would be a list of states that we guess would be impacted. So our fourth big topic, and this one may be a little weird to hear about as providers. We've clearly noted that states get generous matching dollars for every state dollar they spend. But it turns out that states are mostly broke and struggle to fund their state share. One way that they can raise money for that state share is by taxing providers and then using that money to fund their state share or a part of their state share. The providers most commonly taxed are hospitals and a few types of care facilities, nursing facilities, etc. But it can be others. This is very normal in Medicaid. Every state does this except Alaska. About 17% of the national state share is raised through some kind of provider tax like this. So that means 17% of state dollars and all of the corresponding federal matching funds are dependent on this provider tax provision. So this is a huge slice of Medicaid funding, and it's in particular a very important life raft when states find themselves with a budget hole, right? They can use this to fill that hole in hard financial times. States vary in the amount and types of provider tax they use, so it's a little hard for me to tell you which states are most at risk on this. And this is sort of a rabbit hole, but you should understand that in practice, the providers actually usually support the tax. States often develop the tax in collaboration with, let's say, hospitals, because when the state has a budget hole, the tax can, among other things, support provider rates that would otherwise get cut. So the GOP proposal would reduce, potentially even eliminate, state ability to use provider taxes, thus reducing what a state can raise for Medicaid, which in turn means they don't get federal matching dollars for that money. The GOP proposal would reduce this option, and that would, according to them, save $175 billion. CBO has estimated a full repeal of the tax would save, again, $609 billion. So their proposal does have a lot of room to get worse here, a fact we may come back to. Okay, our fifth and final major bad idea is a work reporting requirement. This proposal could force states to use a work requirement, meaning people would need to successfully document employment in order to keep their Medicaid coverage. The work requirement leads to massive loss of enrollment and suppression of new enrollment because so many people, including workers, can't stress this enough, including workers, get terminated or denied when the reporting requirements trip them up. Just to give you a stunningly relevant and timely example we have here, over a year ago, Georgia started a Medicaid expansion with a work requirement, the only one in the country right now, and has a total of 6,503 enrollees. North Carolina started their traditional expansion with no work requirement after Georgia, and in less time has over 600,000 people enrolled. I don't say that to make a statistical prediction that the work requirement will in fact have a 99% suppression rate on enrollment. It's just to illustrate how suppressive it can be. The GOP proposal lists this as saving $100 billion, similar to what CBO has estimated. That's an important point we'll come back to. And one final point, while the Republicans have been all over the place on this whole process, really, literally the only thing they all seem to be quite in agreement about is that work requirements should happen. So this is the one idea that seems the most likely to be a part of the final package, whatever that final package is, though of course nothing is certain. So we do have a long list of other items on the menu. We don't have time to go through them all. We haven't even had time to research all of them. But I want to flag, and this isn't the whole list, I just gave you the most important tier. But I want to flag something about the first four, which could not possibly make sense to anyone outside of Washington, D.C. This is not good news, but in our current environment, it may be like bad news that's not as bad as the alternative. So if you kind of squint and look sideways, you might say it's helpful. When a new administration comes in, they sometimes dislike regulations done by the prior administration, and they initiate a regulatory process to yank the regulations, right? This is a normal process that happens. The Trump administration has these 4 Biden regulations, at least, that are not yet fully implemented and which they don't like, and they want to kill those regulations. But they could do that through the normal regulatory process, but they are not going to do that through the normal regulatory process. Instead, they're going to pass law that effectively repeals the regulation. And the reason they're doing it that way is that then they can count the savings related to those regulations as part of their budget reconciliation package. And when you add them together, repealing those 4 regulations will bag them $332 billion in savings. So we're mostly talking about helpful policies that haven't yet happened. So the Republicans would sort of be getting some savings in a way that doesn't make things worse than they are today. It's not really good news because we lose future improvement, but we don't get worse from our today baseline. Okay. So I guess that's what good news looks like in 2025. So I want to just close out by giving a sense of how these cuts then play out in states. What does this mean when they lose all this federal money? So as we've said, right, any combination of these policies are making large cuts to federal Medicaid funding, and in fact, are not savings, but a large cost shift onto states. States would, in theory, have to dramatically raise taxes or severely cut other parts of their budget, especially that 43% that we saw that they're spending on education, to make up the gap, right? And as we've said, they can't use their provider taxes, or might not be able to, which is like one of their most important tools to raise cash. It's really, really important to remember, right? States already run Medicaid on the bare minimum of funding. You see the rates, right? Like raise your hand if you get paid an overly generous rate from Medicaid, right? I can't see all of you, but I know nobody's raising their hand. So in this kind of a situation where the states lose a ton of money and their program is already has no fat. There's no fat to trim. Um, they do three things. They cut eligibility, meaning less people are covered. They cut benefits and access to benefits, and they cut provider and plan payment rates, right, which are already the lowest out there. And just to say a little bit more about the cuts the states would probably make, Medicaid has mandatory populations and services that states cannot cut, at least not legally. So they can't stop covering children living in poverty or drop ER services. But the good news slash bad news is that the majority of states, all the states, are out there spending money on optional populations and optional services. States are doing a lot more than the bare minimum. More than half of what they do is above the bare minimum. So that optional spending is sort of prime target for cuts. And some of those things are things we really care about, right? So many services for older adults, people with disabilities, would be at risk since many of these services are optional and quite expensive, right? One example would be a lot of the really important home-based care services that these populations depend on. In addition to cutting optional services, states would also tighten access to all services, right? Um, creating barriers and putting friction in the system, reducing the scope of services so you can get therapy, but only 3 times a year, or making it harder to access the services, right? So it's still a covered service, but now there's a much higher standard that your doctor has to write to actually get you the service, and of course, adding more cost sharing. States could do this directly, or they could do it through managed care. They could do it through their existing managed care. Some states could move to managed care to address this cost issue. And of course, as we said already, provider rates would be one of the first things thrown overboard. Um, Beyond our red alert for legislative threats, I just thought you would all want to know about a few less urgent administrative threats that are coming in the next year. The Biden administration advanced 3 new policies that may be at risk of administrative, again, not legislative, administrative repeal. The first is multi-year continuous eligibility, targeting in particular children age 0 to 6, but also some other populations. And what this does is it basically locks in coverage for kids that get enrolled for the duration of their first 6 years of life, meaning they don't get terminated all the time at redeterminations and constantly fall off coverage, as is the case now. Second, Medicaid investments in health-related social needs, particularly nutrition and housing, that are supportive of clinical care, related to clinical care. And third, special Medicaid coverage to support transitions out of state carceral settings, prisons, jails, and juvenile detention facilities, because we have some of the worst healthcare outcomes specifically for that population. So on this last slide, I just have listed some resources for you that will help you keep up to date. We have a blog where we sort of put updates on this process, so you'll see periodic blogs on this. We have a state data hub with information about your state Medicaid policies and performance, especially as relates to children and families. We also have state fact sheets about the value of Medicaid and a series of video classes, kind of like this presentation that you can watch on a whole assortment of topics. And I have 2 colleagues that are on Twitter and other social media who are great to follow if you want to keep up. And I would recommend you do that. So with that said, that's formal presentation now. So I'm going to punt to Raj, who's going to lead us through Q&A.
Thank you so much, Mr. Okoye. That was such an informative presentation and a really good rundown of all the different aspects that are in play right now. I think especially with the way the news cycle is, it can just be really overwhelming at times to hear all the news that's coming in, all the updates, and not just on Medicaid, but on myriad other issues that are also being threatened right now. So that's really useful to have all that data in one place and have the arguments in one place as well, so we can easily reference them. Just wanted to ask you a little bit more about now that we have kind of the baseline information, what can you say about the kind of political dynamics right now and all the possible outcomes, and especially what might be happening in the next week to 2 weeks?
Right. So I was telling Raj and Sophia before we started that just in talking with people who are on the Hill, they say the next week is really, really critical. And the reason for that is there's going to be a House floor vote on their $880 billion target on their whole package, which includes that 880 target, not in the policy, but remember just that first step of locking in that number. Once that number gets locked in, then we have a real problem because there is no way to cut 880 billion out of this program without doing major damage. So their timeline may slip, but they are hoping to put that to a floor vote next week. So it is however you feel about this issue, it is a watershed moment. My role here is I'm nonpartisan in this. I'm here to provide you with information. But here's what we know, that the Republicans do control both chambers of Congress and the presidency. So we can kind of ignore the Democrats for the purpose of this process. In the Senate, there are two senators who have consistently been unlikely, Republican senators who have been consistently unlikely to go against Medicaid. But the GOP majority can actually afford to lose three senators. So to defend Medicaid, you need to get the two that you have a good chance of getting, and then two more. And whoever is number 3 and number 4, that will not be an easy, that will be a person who is 50-50 to begin with, and this will be a really hard vote for them to take, and they'll be under intense pressure. So perhaps unlike 2017, where the Senate was the place where that attempt to, you may remember the John McCain thumbs down, it was the Senate that was really the tight spot there. This time it's in the House. The House majority is slimmer, where the House can only afford to lose one vote. So that's likely to be where the action is, whether this lives or dies. Especially pivotal will be Republicans in bluish districts that have, or districts that have high Medicaid enrollment, where they will have a lot of concern about making these huge Medicaid cuts, and they have been out there voicing those cuts. Now, remember I said that both the House and Senate must come to agreement, and they are actually right now quite far apart, actually, even in their approach. The House approach is to do one bill that has all of these things we've talked about. The Senate approach would be a much skinnier approach, where they would only do border and energy and defense, and they would not do tax cuts, and they would not do spending cuts, right? And they would punt the tax cuts and spending cuts to a second package later in the year. So two very different approaches. Making matters even more confusing, President Trump has gone back and forth. So it's hard to know exactly where President Trump is. He has said in the past 2 weeks he cherishes Medicaid, and that he won't touch Medicaid. And he has also said that he is going with the House version. So very hard to understand what is happening there, although his statements supportive of Medicaid are very helpful as you talk to Republicans who are in the middle and don't know what to do. Now, in terms of the numbers, the last thing I wanted to talk about, we have this possibly 880 target out there. Remember that final House floor vote has to happen. So we don't know if 880 will get support. Before they released that 880 number, literally the day before, they were talking about a number that was in the range of 200 to 300. And they had said, we will only cut work requirements and fraud in Medicaid. Now, as we've covered, work requirements are 100 billion. So if 880 is the target, something gives. Like there's $780 billion in Medicaid cuts that we're not being told about, right? So there's an issue there. Those regulations I talked about could be very helpful, because now when you add the 100 billion for work requirements to the 332 billion of those regulations, now you get to 432, but that still only gets you to half of that 880 number, right? So they are going to need to either change their number or find more Medicaid cuts. Early on, it sounded like the biggest risk was to Medicaid expansion, because they just don't like the fact that Medicaid expansion provides coverage to adults. Part of it is that they sort of have a fiction that adults can just get health insurance from their work, and they don't understand how many people in Medicaid are working families that don't have insurance available to them through work. They just don't understand that fact, or it doesn't sink in well. So early on, it looked like they were going to either target the Medicaid expansion match or target a per capita cap on Medicaid expansion. That's what I would have told you 2 weeks ago. Um, lately, especially with President Trump weighing in, they've shifted to a talking point of we're going to do things, but we're not going to hurt people. So lately, it seems like they are headed more towards the provider tax. So that appears to be um, at higher risk right now. This is kind of like the stock market, right? Where I'm just telling you what stock is up and down, but tomorrow anything can happen. The other place where I think because of statements from President Trump and others, clearly they could throw some kind of thing targeting immigrants into the mix. So that's where we are. Very pivotal moment because if they lock in that 880 number next week, then it becomes a much bigger uphill climb.
Thank you. That's all really useful to know. Kind of along that line, as you mentioned, the administration and Senate majority are seeking to implement these cuts via the budget reconciliation process, at least in the Senate side, with a civil majority to avoid a filibuster. But under previous Senate norms, who knows if those are still in place now, but under previous norms, certain criteria were in place to determine what qualified for budget reconciliation. Are there any components that you think are less likely to qualify for reconciliation, or do you think everything in Medicaid is basically fair game because it applies to the budget?
Um, I definitely wouldn't say like a very broad, everything is fair game kind of approach. Um, but I do think there are a lot of things that are going to be okay because there are a lot of things here that, um, that impact the budget. Um, there probably are a lot of details. And remember, we have no policy details here, right? So this is all very bare boned right now. When they start putting that flesh on, there may be things that look like they fail the budget reconciliation standard. Um, and some of this I think will boil down to a question like if they just um, cut funding for states in a punitive way, not based on policy, would that be considered a budgetary thing? Like, so there are questions out there where there are a lot of places where they could run into trouble with that. What I will say though is that is a food fight that is coming to a theater near us, but we're not there yet. We have to prevent that 880 number from happening. If you want Medicaid to be protected, you really don't want that 880 number to be there. Because once that 880 number is there, you can get in fights about this or that should not be in the package, but you're going to have such a big target to hit that one way or the other, it's all going to sink. So, if your goal is to prevent cuts, then I'd say that's where the focus is right now.
That definitely makes a lot of sense. And as you were mentioning earlier, it definitely seems like with the tight margins, there are some opportunities for us to really make an impact, specifically in the House, but even potentially in the Senate. Although it seems like that House majority, the slim one vote majority, will definitely be a target for us moving forward. Kind of what you're mentioning about the current proposal being so bare bones and not really knowing exactly how things are going to shake out, at least with final numbers and that sort of thing. There have been some questions in the chat about kind of the fact that there doesn't seem to be something like a clear proposal on the ground right now. And I know you're mentioning that it seems like a lot of the folks have been flip flopping back and forth on what they want to include. So somebody asked, what would you recommend that healthcare professional organizations do, such as the American Medical Association or other specialty societies, to prevent these cuts in Medicaid? For example, I think from a lot of the organizations, some of them have been mentioning that there's nothing, there's no specific bill on the table, so therefore there's nothing specifically actionable. And I think we know that that's not necessarily true. So do you have any thoughts on kind of what to kind of point to get other organizations to also act on this to amplify our message?
Yeah, it's a great question, and it's something we always struggle with. So I do want to start by just making a point about the premise here, which is that you don't have something specific to respond to. The reality is that's part of their strategy. If I think if the Republicans could have their druthers, what they would do is put something on the floor for a final vote that they have all come to a clear understanding of, and we haven't even seen yet. because there's less time for people to analyze it, less time for people to raise concerns. The longer their ideas sit out there, the more people have to realize, oh, this is a bad idea, right? So while I understand that it's hard to push back against something that doesn't have a shape yet, um, you can't let that be your litmus test, because that's kind of part of the strategy that may be going on. That said, you know, so I think the provider community is so special and essential to this process. The American people don't trust politicians. They don't trust lawyers. They don't trust me. They trust their doctors, right? That's just a fact. Um, and so the provider community, speaking with a clear voice, has a cachet, a reputation, a level of trust. Um, Obviously, the perception and reality of independence, because we all know you're going to bat for your patients. Um, so I do think it's really important to have people weighing in. And I'll tell you one of the good things, because right now the policy is such a mumble jumble and we don't know what's going to come out. We actually, you know, have been sort of saying, listen, all of these ideas are bad. Just no Medicaid cuts. There should not be Medicaid cuts as part of a package to do these tax cuts. So I don't think, an 880 implies cuts that are just impossible for the program to absorb. So I don't even think you need to go into all of the policy to make a statement that's really clear and really helpful. To providing education to your state community, the stakeholders in your state community. So, what I want is, I want data-driven decisions. I want the facts to be out there, and I want people accountable for the decisions they make with public monies, right? And I think you all have an incredible role in helping make sure that people actually understand what this means, and the people who make decisions are actually held accountable for those decisions if they're bad ones.
Thank you. That's also really useful to hear. And the person who asked that question is absolutely correct. So far, it seems that the American Medical Association has perhaps arguably the biggest or most prominent of the medical organizations. Is so far, they've been publicly silent on the issue of Medicaid cuts. Although I just want to note this statement that was put out by the various national specialty societies representing family medicine, internal medicine, and internal medicine subspecialties, pediatrics, OB-GYN, and psychiatry. They put out a joint statement about Medicaid being protected, and I've at least gotten a couple emails from a couple of those organizations that I'm members of, with calls to action and to template letters and that sort of thing. So at least a good sign there that we have some of the groups speaking out against this. This actually, your point about doctor trust actually segues into another question somebody asked. And I'm sorry, there's great questions in the chat. I don't think we'll be able to get to all of them tonight. But thank you all for asking those, and we'll definitely try to follow up Mr. Pueo afterwards if he's willing to get you some answers to those later on. But somebody asked, in many cases, it seems like some of the people that might be supporting the administration or supporting the cuts that are happening might actually be the ones that are benefiting from a lot of the public health insurance programs that are being funded by the government, and specifically Medicaid. So do you have any suggestions for how we can make that case to the general public and or our patients when it seems like there might be some dissonance between those two things?
Yeah, there is a lot of dissonance out there. There's dissonance in two ways. One is that, in the poorer states, there tend to be higher proportions of a lot of different types of populations on Medicaid. So there's more people enrolled. And as we said, they are often getting the highest matching rates. So they are getting more federal dollars than other states for the amount of state spending they make. So in a weird way, the program benefits somewhat disproportionately a correlation of states that somewhat disproportionately vote against the program, right? This is like one of the many mysteries of the universe that you work through. So a lot of that, though, boils down to really helping people understand what the program is doing. And I'll give two examples. The first one, we have a report on how Medicaid impacts rural areas. So, yeah, it's not that urban hospitals don't ever go bankrupt, but the hospitals that go bankrupt are rural ones. Like, over 80% of the hospitals have gone bankrupt in the last 20 years are rural hospitals. Medicaid is essential to rural hospitals. And rural hospitals are often the only big employer in their county, a gigantic source of tax revenue for that county. The county loses that rural hospital. It's like 100 different types of mess all rolled into one. People who live in rural areas understand that and are proud of their local hospital, right? They understand that if this hospital closes, I know, and they may already have a half-hour drive to that hospital, the next closest hospital is 2 hours away, right? They understand that. They understand that there was no OB unit anywhere near me, and I had to drive 2 hours for my, prenatal appointments. So they understand that this hospital is the biggest employer in their county, and we can't have that hospital closed. So we need to connect Medicaid to what it's doing for them systemically that they don't understand. The other big one that's out there, the majority of nursing home residents are paid for by Medicaid. Nobody in this country understands that. Anybody you say that to the first thing they will tell you every time is, oh, you said Medicaid, you probably meant Medicare. No, right? Medicare actually doesn't cover nursing homes. It has a relatively limited acute care rehab benefit, right? And they try and move you out of that rehab unit pretty quickly. So Medicaid is paying for nursing homes. So you have this whole contingent of people who think they don't like Medicaid. And it turns out that their mom or their grandma is right now in a nursing home being paid for by Medicaid, right? You also have this contingent of people who may have $300,000 saved up in a 401k and think of themselves as independent, but they are one stroke away from a facility that costs them $8,000 a month, right? And 3 years from now, they're on Medicaid too, right? And these people were my clients. So, this is real. This is what we have. So Medicaid is doing this and people don't know it, right? So really drawing that connection for people between what Medicaid is doing in their communities. And when you tell people, guess what? Half the births in your community, Medicaid. Half the kids in your community covered by Medicaid. More than half of the people in nursing homes in your community covered by Medicaid. That really does start to move the needle with people so that they understand the value of the program. Storytelling is really important in this, and providers are amongst the best and most trusted storytellers, I'll just add.
Thanks, Mr. Quay. That's also really helpful. And I think actually answers another question that somebody had about kind of suggestions for talking points or things to bring up with members of Congress or policymakers when we're discussing these. Not just pointing out that, of course, in addition to Medicaid being an absolutely important form of access to care, it's also so crucial to all these other kind of anchor institutions and other crucial components of our societies and communities. I think it's another way to really make that case, especially to people who might not necessarily be as invested, unfortunately, into arguing about access to care.
Yeah, another one that I forgot, 20 years ago, in the sort of reddish states, we were doing very badly on understanding and recognition around behavioral health. Unfortunately, we have had this devastating opioid crisis, which has led to a lot of people suddenly understanding this problem. And so when you tell people the largest source of coverage for substance use disorder treatment is Medicaid in rural communities, do you want to take that away from people? That too immediately gets people taking a step back and saying, whoa, wait a minute. I didn't realize that.
Absolutely. No, that's a really, really great point to also highlight as well. So keep that in mind for when you're contacting your policymakers. And of course, you'll all have access to this reporting and the slides afterwards to always make sure that you can easily reference these arguments again. And just somebody briefly asked about what the American Hospital Association was doing about this. So I'll just put in the link, put in the chat as well, a link to one of they put out a number of different fact sheets and statements around Medicaid cuts. So there definitely do seem to be several groups working on this, even as some other groups have not been as active. Well, I'm so sorry that we can't answer and we don't have time for more questions. We are at the end of our hour. But thank you so much, Mr. Quay. I really, really appreciate your time and all of your expertise. Can't say enough how important this is to really educate us, especially at this most crucial time, especially as you mentioned, the next week being such an important turning point in this whole discussion.
Well, thanks so much for having me and for all the work you all do. I am just really impressed that you guys can do what you do during the day and then have the bandwidth to do this. It is really, really important to the field to have the medical community so engaged. I really appreciate you.
No, thank you. I mean, it's only possible for us to be able to kind of do this sort of work by having folks like you as our allies doing the work full time, so we can kind of just mooch off the end there and take what you teach us. So it's all because of you, thankfully. So I just want to recap briefly, and then we'll go on to some kind of upcoming actions and ways that you can get further involved with DFA moving forward, especially on Medicaid cuts in the next week and in the coming weeks ahead. So today's presentation highlighted the really significant threats facing Medicaid, including funding cuts and restrictions on coverage, all in the name of saving costs, when really this is just impacting tens of millions of people's lives. Mr. Quay's insights have equipped us with crucial information and strategies to advocate for the preservation of Medicaid and protect the healthcare of our patients who are most in need. I think sometimes those on the policy side might assume that we as physicians or health professionals or students in those fields aren't business or insurance experts. And so sometimes they might tell us to stick to our lane and just stick to the science and patient care and to stay out of all of this kind of more financial aspects of healthcare. I think it's really crucial that we push back as a profession against those conceptions by showing that we know these policies too. We've taken the time to build our own knowledge thanks to people like Mr. Quayo. We know the data, we know the impacts, and we can repeatedly make the case that the policies made in DC are inextricably linked with the care we provide in hospitals and clinics all across the country. We can't care for a patient that doesn't have access. And as Mr. Quay mentioned, this is also so important to all the different anchor institutions that make up our communities and the backbone of our society. So as far as people who are wondering about different ways to be involved with Doctors for America, to start, we can register for our Docs on Call event, actually happening next Thursday, February 27th at 8 p.m. I believe that's 8 p.m. Eastern, but correct me if I'm wrong, Sophia. So a DFA team member will add the link to the chat. We'll be teaming up and placing calls to our legislators to share our thoughts on the importance of protecting Medicaid. And again, as Mr. Quay mentioned, this is a really time-sensitive point, so you want to hopefully have the best possible turnout at that call, in the hopes that we're still making it just in the nick of time with all these discussions occurring right now. You can also take a look at the new Protecting Medicaid Advocacy resource that DFA has created, which is also going to be posted in the chat. This provides a bunch of information on actions you can take, such as how to contact your legislator by requesting a meeting or making phone calls, sending emails, or sharing your stories on social media or your local town halls. And it gives guidance on how the small actions that you each can take can make a difference. So even though we hope that you all will join us for our Docs on Call event next Thursday, that does not mean you have to wait. You can get started right now or tomorrow, whatever is best for you, and continue and start taking those actions in the coming days, even as we're kind of amplifying our message next week. And also, please feel free to join in our monthly DFA calls focused on access to affordable care. We'd love to have you join our committee, even if you just want to kind of come as an observer, see the kind of work we do, try it out for a few weeks, and then see if you want to kind of join on a more permanent or more consistent basis. That's totally fine. We love having people kind of trialing us out before they decide if they want to stay for a longer period of time. And those calls are every second Wednesday of the month from 8 to 9 p.m. Eastern. And again, I think we have a DFA team member who will tell you how you can get involved and connected for those resources as well. So I'd like to close the session by thanking again our speaker, Mr. Quay, for this thought-provoking discussion. We are so grateful for your time and expertise. And a couple of quick reminders. Education is important and so is action. So after tonight's session, please again look at those links that our DFA staff has posted in the chat regarding our Docs on Call event next Thursday and our Protect Medicaid Advocacy resource. And other ways that you can also be involved are by writing an op-ed to your local paper or a letter to the editor, or even submitting a commentary to a medical journal, for example, like the JAMA Viewpoint, or various other journals that will publish, commentaries and editorials and those sorts of writings. Although keep in mind that the timeline for those tends to be a lot longer. So you might want to also plan some more immediate actions in the short term before planning for those actions in the longer term. And also, please try to share what you've learned here tonight with your friends and colleagues in the healthcare setting and elsewhere. The recording will be available. It will also be posted to the Doctors for America YouTube page. So you can also share that link freely with anybody who'd like to watch and catch up on the event later as well. And of course, if you have other people who are interested in joining DFA's work, please bring them along. They're welcome to join our meetings and all that. So we love to have as many people as possible to really amplify our message. The amount of work we can do is directly proportional to the amount of volunteers that we have. So it's always what we're looking for is more volunteers. So please watch for additional opportunities to provide input on future policy issues. And for those of you that are paid sustaining members of DFA, just a reminder to complete the survey for 1 credit of CME for attending this session if you'd like to claim that. Thank you again for being here and for all you do on behalf of patients. We also, again, hope that you'll become an official DFA member today to support all the great work that we're trying to do, especially at such a crucial time in American healthcare politics. And please take a look at the benefits of membership on DFA's website. The number one reason doctors, medical students, and health advocates join DFA is to be with like-minded people that share the same values and priorities. And also, please remember to follow us on Blue Sky, Twitter, Instagram, LinkedIn, and Facebook to stay up to date with all DFA programs, events, and ways to get engaged. All right. Thank you all so much for attending. Again, so great to see such an awesome turnout, and have a great rest of your evening. And let's get to work. We can start tonight.